Hi, my name's Nathan Akins, and welcome to my video on assessment of COPD and a typical patient. The typical patient that I'm going to assess today is a mild to moderate COPD patient who's having his first exacerbation, likely brought on by a viral or bacterial respiratory tract infection. Patient A is a 62-year-old Caucasian male who presents with what he believes is a respiratory infection or chest cold. Though the patient has had a productive cough most mornings for several years, the frequency of the cough has increased, and it has begun producing copious amounts of thick greenish sputum for 10 days. Other symptoms are increasing dyspnea on exertion with some wheezing and worsening fatigue. The patient has needed to use his inhaler more frequently. The patient is a former smoker of 2 to 4 packs per week. He began to try quitting 2 years ago when he had his heart attack, but was only able to quit 1 year ago. 2 years ago, the patient did have a heart attack, and he received 2 cardiac stents at the time of his hospitalization. His other medical history includes obesity, coronary artery disease, hypertension, pre-asthmatic, and treatment for pneumonia 5 to 6 years ago. The patient is currently taking the following medications: aspirin, clopidogrel, lisinopril, metoprolol, atorvastatin, and an albuterol inhaler, which he uses as needed for wheezing and shortness of breath. Vital signs of the patient were taken. His heart rate was 63 and regular, respirations 22. His blood pressure was 127/62, and he was slightly febrile with a temperature of 99.1 degrees Fahrenheit. As the patient walks in, I visually assess the patient to note if he has short of breath while walking or if he's frequently coughing. Is he the patient breathing through pursed lips to prevent airway collapse, or is he leaning forward, or is he sitting down leaning forward with his hands on his knees to increase lung capacity? I also note if he is barrel-chested or thin, as is common with emphysema, or if he's obese, as seen in early chronic bronchitis. Is the patient anxious or nervous? Is the gait and skin coloration look normal, and does he generally appear healthy? Okay. Symptom assessment is important with COPD, as it's useful for physicians to gauge how well treatment regimens are going, or to improve management of certain symptoms to improve quality of life. As I have already stated, the symptoms that the patient has reported to me. At the time, I've also done a neurological exam. Any neurological changes in COPD are from hypoxia and considered a late-stage symptom. Patients suffering from hypoxia may get confused easily or may not answer questions appropriately. Having a spouse, family member, or caregiver present during the exam may help with noting subtle signs such as incorrectly answering historical questions. COPD is associated with hypertension, pulmonary hypertension, heart disease, heart failure, and atrial fibrillation. Assessing cardiac function is an important part of the COPD assessment. First off, long-term hypertension can cause mitral valve, aortic valve, and tricuspid valve regurgitation. So I will auscultate for adventitious heart sounds. Any murmurs or gallops may indicate valvular heart disease. Another important part is to check for pitting edema, as this may indicate cor pulmonale or fluid overload. You want to assess the lower legs and feet when looking for pitting edema. Lower legs, ankles, and the feet. You want to push and release. If the skin turgor does not bounce back right away, then that may indicate excess fluid overload and pitting edema. Other signs you want to look for are jugular vein distension. You want to look and check both sides of the neck. No need to palpate, and look to see if you can find a pulse or a beating or a distended jugular vein. Also, while you're taking the patient's blood pressure and you can feel their pulse, You want to check for any irregularities. If the heart rhythm is regular, then that indicates sinus rhythm. But COPD is associated with an increased rate of atrial fibrillation, so an irregular or erratic pulse may indicate this. Next, I want to move to the respiratory system. I'm visualizing the patient breathing. I'm watching it for any pursed lip breathing or the use of accessory muscles to aid in ventilation. Next, I want to have the patient take a deep breath. I'm watching for how long it takes the patient to exhale. Prolonged exhalation is a product of air trapping caused by the COPD. Finally, I want to auscultate the lung fields for adventitious sounds. Move forward. Take a deep breath. Again. Again. Out. In. And out. And once more. And out. You want to auscultate all 5 of the lobes, 2 on the left, 3 on the right. You also want to go back and forth in a crisscross pattern so that you can evaluate the difference between the two. Wheezing and rhonchi are associated with COPD, whereas crackles, a more wet sound, are associated with heart failure and a buildup of extra fluids. Stable emphysema may have little noise, but may have diminished breath sounds. And diminished breath sounds on one side only may indicate a pneumothorax. Gastroesophageal reflux is common with COPD. When assessing symptoms, ask the patient if they've been having increased incidence of heartburn or epigastric pain after eating. Next, we want to look at the chest. A barrel-chested look is common in patients with emphysema, but it may also be associated with chronic bronchitis. Musculoskeletal dysfunction is seen in patients with COPD due to malnutrition and activity intolerance. With severe COPD, the patient may appear cachectic with obvious signs of muscle atrophy and weight loss. Increased coughing has been known to cause rib fractures, so if the patient reports an increased cough and sharp pains on inspiration, the ribs should be palpated to feel for a sharp pain. In general, COPD does not affect the genitourinary system. However, hypertension and diabetes mellitus is strongly associated with COPD and are causes of chronic kidney disease. Chronic kidney disease causes uremia and azotemia, which are increases in nitrogenous compounds in the blood and urine that need lab work to evaluate. Increased peripheral edema is possible and an indicator of decreased renal function. COPD can cause both chronic and acute hypoxemia. When assessing the patient, you want to look at the oral membranes. Open your mouth for me. And look for any cyanosis there. You also want to look at the fingernails and look for cyanosis in the fingernails. While you're there, you also want to look for clubbing. Clubbing is a symptom of peripheral vascular disease or hypoxemia to the extremities and occurs over time. Anxiety and depression are often overlooked comorbidities of COPD patients and is more common in younger female patients that still smoke and have a history of heart disease. It is important to screen for this and is evidenced by the first question on the CAT asking if the patient is happy or sad. Patients that are depressed may sleep more than normal or have insomnia, loss of interest or pleasures, fatigue, indecisiveness, poor concentration, feelings of worthlessness or guilt, or thoughts of death and suicide. If a patient is having any of these symptoms, it is important to refer them to a psychiatrist. It is important to also assess a patient's social and spiritual well-being. Isolation is an important issue for COPD patients at end stage. Many end-stage patients are housebound or even wheelchair or even chair-bound, and they often report feelings of reduced quality of life and isolation. Symptom management is important to keep patients as active as possible. And if a patient reports feeling isolated, then family and social support systems should be engaged to alleviate the situation and hopefully prevent possible depression. In this way, spirituality is important as well. Though different cultures may manifest spirituality in different ways, it is important to note that because of social isolation and activity intolerance, patients may no longer be able to participate in organized religions, and this can cause stress and anxiety to many. Religious organizations are also important in that they can be engaged to socially interact with COPD patients and provide fellowship. Thank you for listening to my COPD assessment guide. I hope you found it informative as well as entertaining. It should be noted that most physical symptoms in COPD, though they are seen commonly with emphysema and chronic bronchitis, they are usually associated with later stages of the disease,